Welcome to the Hospital Medicine Unplugged podcast.
Today we're doing a real deep dive, focusing on the evidence-based management of acute exacerbations of chronic obstructive pulmonary disease, AECOPD, specifically for hospitalized patients.
Yeah, our goal here is really to take the latest guidelines, the data, and boil it down into what you actually need to do at the bedside for these folks who are often quite sick.
Exactly. This is bread and butter hospital medicine, but things do change, especially around, say, how long we treat or what we send patients home on. So maybe we should start right at the beginning.
Good idea.
Yeah.
Before we get into the nitty-gritty of algorithms, let us make sure we're all on the same page. How do we define an exacerbation that's severe enough to land someone in the hospital?
Right. So formally, an AECOPD is an acute worsening of their usual respiratory symptoms. We're talking mainly increased shortness of breath, more cough, maybe more sputum, or the sputum looks, more purulent.
And it's got to be worse than their normal day-to-day ups and downs.
Exactly. Bad enough that it needs a change in their regular meds, or, crucially for our discussion, it forces them to seek urgent care, ER visit, hospitalization. We're really focusing on that severe group today.
The ones who likely failed outpatient management or were just too sick to even try it?
Precisely. They're coming in already potentially compromised.
Okay, so they hit the door. Those first few hours are critical.
Yeah.
It feels like mission control, right? You're trying to get symptoms under control fast, prevent complications, figure out what triggered it. But let's talk triage first. What are those absolute red flags that scream, admit now, high risk?
Yeah, there are definite signs you need to pick up on immediately. Some are what the patient tells you, some are what you see. Subjectively, it's that severe shortness of breath, especially at rest. And they'll often say their rescue inhaler just isn't cutting it anymore.
And objectively?
Yeah.
What are we looking for on exam or vitals?
Objectively, you're looking for things like a persistently high respiratory rate, severe tachypnea, or significant hypoxemia, say an O2 sat that just won't stay above 88 to 90% despite oxygen. And probably most concerning is evidence of new or worsening respiratory acidosis on a blood gas.
And we absolutely cannot ignore changes in mental status. That's a huge one. New confusion, drowsiness. You can't just blow that off as their baseline, especially when they're working hard to breathe.
Couldn't agree more. That altered mental status is often your first clue that their CO2 is dangerously high, that they're heading towards respiratory collapse. It needs immediate attention, immediate action.
What other physical signs push you towards admission?
Well, obvious things like using accessory muscles to breathe, that paradoxical abdominal movement you sometimes see, or new physical findings like cyanosis, maybe new leg swelling suggesting heart failure kicking in, and just plain failure to improve after initial treatment in the ED. You give them aggressive nibs for a couple of hours and they're still struggling, they need to come in.
Okay, so they're admitted. We need to work them up, quickly confirm severity, but also, crucially, rule out things that look like AECOPD but aren't. What are the essential first tests?
Top of the list, especially if you're worried about high CO2 or acidosis, is an arterial blood gas, an ABG.
Yeah.
That pH less than 7.35. That's a key threshold, often triggering things like non-invasive ventilation. It really quantifies the respiratory failure.
In imaging.
A chest X-ray. Non-negotiable, has to happen fast. You're looking for pneumonia, which changes your antibiotic plan, or something catastrophic like a pneumothorax.
And don't forget the heart. These patients are often stressed, hypoxemic.
Absolutely. An ECG is mandatory. You need to check for arrhythmias, especially with the beta agonists we're giving, or signs of cardiac ischemia. Heart failure is a super common mimic or contributor, and it gets missed if you just anchor on COPD exacerbation.
That anchoring bias is dangerous here. We really have to force ourselves to think broader. What about those non-infectious causes?
Right. Heart failure, like we said. And pulmonary embolism, PE. PE can look exactly like a refractory AECOPD. You have to keep a high index of suspicion, especially if they're not responding as expected or have risk factors. Don't be afraid to check a D-dimer or get a CT scan if it doesn't feel right.
So important. Now back to triggers. While we hunt for mimics, infection is still the most common cause, right?
Yeah. Most of the time it's infectious. Respiratory viruses, rhino, flu are very common. And then there are the usual bacterial suspects. The big three we worry about are Haemophilus influenza, strep pneumonia, and Moraxella caocasi. Got to cover those empirically usually.
And don't forget things like air pollution or patients just not taking their maintenance inhalers or still smoking. Those definitely played a role too.
For sure. Okay, so patients admitted, initial workup is rolling. Let's talk respiratory support. Step one is often oxygen, but this isn't a more is better situation, is it?
Definitely not. There's a very specific evidence-based target range for oxygen saturation here. What is it, and why is it so crucial we stick to it?
The target is an SpO₂ between 88 and 92%. We actively avoid pushing it higher, like to 95 or 100%. It seems backward, but higher oxygen levels can actually worsen their hypercapnia, their high CO2, and make the respiratory acidosis worse.
Can you break down why that happens? People often mention blunting the hypoxic drive, but it's a bit more complex than that, right?
It is. So yes, part of it is the traditional explanation. In some chronic CO2 retainers, their main drive to breathe comes from low oxygen, the peripheral chemoreceptors. If you give them tons of oxygen, you take away that stimulus, their breathing slows or gets shallower, and CO2 climbs. That's the blunted drive part.
But there's more to it physiologically.
Yes, arguably the bigger issue involves something called the Haldane effect and worsening VQ mismatch, ventilation-perfusion mismatch.
The Haldane effect. That's where oxygen binding to hemoglobin kicks CO2 off.
Exactly. High oxygen saturation reduces hemoglobin's ability to carry CO2, so more CO2 dissolves in the plasma, raising the PaCO2. But even more importantly, think about VQ matching. In COPD, you have areas of the lung that are poorly ventilated but still getting blood flow. Normally, the body tries to compensate with hypoxic pulmonary vasoconstriction, or HPV.
Shunting blood away from the bad lung areas.
Right. Low oxygen around those bad alveoli causes the local blood vessels to clamp down, redirecting blood to better ventilated areas. It's a protective reflex, but if you flood the lungs with high-flow oxygen, you overcome that local hypoxia. The HPV relaxes, and now you're perfusing all those poorly ventilated areas again.
Which dramatically worsens the mismatch between ventilation and perfusion.
Precisely. You increase the physiological dead space lung that's getting blood flow, but not participating effectively in gas exchange. This makes it much harder to clear CO2. So sticking to that 88–92% target is vital to avoid making things worse.
Okay, so controlled oxygen is step one. But what if, despite that and optimal bronchodilators, the patient is still acidotic, still working incredibly hard to breathe? What's the next step?
That's where non-invasive ventilation, or NIV, usually BiPAP, comes in. And the evidence here is really, really strong. It's considered the first-line ventilatory support for these patients.
Why is it so effective? What does it actually do for the patient?
It works wonders, honestly. Multiple large randomized trials show that starting NIV early significantly cuts down the need for intubation and mechanical ventilation, and it lowers hospital mortality. It basically does two main things.
Okay, well, all right.
First, it helps rest the patient's respiratory muscles, which are often exhausted. Second, it helps counteract the dynamic hyperinflation, the air trapping that's making it so hard for them to breathe effectively.
That air trapping is a killer for them. How does BiPAP help with that specifically?
It's mainly the EPAP, the expiratory positive airway pressure, which acts like PEEP. See, these patients develop intrinsic PEEP because their airways collapse during exhalation, trapping air. This makes it harder to trigger the next breath. By providing external EPAP, you essentially stent open the airways a bit, counterbalancing that intrinsic PEEP and reducing the work needed to start inhaling.
And the IPAP part, the inspiratory positive airway pressure.
The IPAP gives them a pressure boost during inspiration. This increases their tidal volume, helps blow off more CO2, and further rests those tired respiratory muscles. It's a powerful combination.
So who exactly needs this? What are the hard indications on that ABG or at the bedside?
The prime indications are, number one, acute respiratory acidosis. That means an ABG showing a pH less than 7.35 and a PaCO over 45 millimeters of mercury. Also, severe dyspnea, where you see them using accessory muscles clearly struggling. Or persistent hypoxemia that isn't responding to the controlled oxygen and medical therapy. The key is starting it early before they completely tire out.
Let's talk settings. If you're initiating BiPAP, where do you typically start and how do you adjust it?
You usually start with an IPAP around 10 to 15 centimeters of water and an EPAP around 4 to 5. You want a pressure support gradient, the difference between IPAP and EPAP, of maybe 6 to 8 initially. Then you primarily titrate the IPAP upwards to improve their breathing, get good tidal volumes, and lower the CO2, watching the blood gas.
How high can you go with IPAP?
You know, some recent studies suggest that in stable patients who can tolerate it, you might need higher IPAP settings, maybe up to 20 or even 30 centimeters of water, to really effectively clear CO2. But you have to watch closely for tolerance, mask leak, and air swallowing.
And how long do they need to be on it? continuously?
Initially, yes. The recommendation is continuous NIV for at least the first 24 hours. Give those muscles a real chance to rest and recover. Then you start weaning based on improvement, pH normalizing, CO2 coming down, vital signs stable, patient looking more comfortable.
Just as important is knowing when not to use NIV or when to stop and escalate. What are the absolute contraindications?
Right. NIV is out if the patient can't protect their own airway, if they're very drowsy or unresponsive. Also, if they're severely agitated and won't keep the mask on, or if they have tons of secretions they can't clear. Facial trauma that prevents a good mask seal is another one. And of course, if they're hemodynamically unstable, like in shock, NIV requires a cooperative, conscious patient.
And if they meet those contraindications, or if they're on NIV and just getting worse, pH still dropping, oxygen still low, getting more confused, that's when you had to pull the trigger for intubation and invasive mechanical ventilation.
Exactly. NIV failure is a clear indication to escalate. One quick word on high-flow natal oxygen, HFNO.
Good point. Where does that fit in?
HFNO is great for supporting oxygenation, especially in pure hypoxemic respiratory failure. But for the typical AECOPD patient with hypercapnic failure, it's generally less effective than NIV because it doesn't provide that pressure support needed to reduce the work of breathing and really help blow off CO2. It might have a role maybe as a step down from NIV, but it's not the first choice for severe hypercapnia.
Okay, great clarification. Let's shift now to the medications. Pharmacological cornerstones. Starting with bronchodilators, these are usually the very first thing we give.
Absolutely essential. The mainstays are short-acting inhaled beta-2 agonists, like albuterol, often given together with a short-acting anticholinergic, like ipratropium. Using both together seems to give a bit more symptom relief than just using one aggressively, though the hard outcome data isn't always dramatically different.
How should we give them in the acute setting? There's always the neb versus MDI debate.
Yeah, in the heat of the moment in the ER, nebulizers often win out because they seem easier, less coordination needed. But the evidence actually shows that a metered-dose inhaler, an MDI, used correctly with a spacer device, is just as effective.
And probably faster and cheaper.
Right. MDI with a spacer is quicker, uses less staff time. Nebulizers are probably best reserved for patients who are really distressed, can't coordinate their breathing at all, or are maybe already intubated. Whichever way you give it, you need to give it frequently at first, maybe every 1 to 4 hours, depending on how they respond.
What should we avoid doing with bronchodilators? Any common practices that aren't evidence-based?
One big one is continuous nebulization. It's sometimes done, but there's no good evidence it works better than frequent intermittent doses, and it definitely increases side effects like tachycardia and tremor. And the other absolute don't is using methylxanthines theophylline or aminophylline.
Still see those occasionally.
Yeah, but they really should be avoided. They add little, if any, benefit on top of standard therapy, but they have a narrow therapeutic window and a high risk of serious toxicity, arrhythmias, seizures.
Yeah.
Just not worth the risk or the monitoring hassle in the acute setting.
Okay, good riddance to theophylline. Moving on to the other cornerstone. Systemic corticosteroids. Pretty much everyone hospitalized gets these, right? Why?
Yes, systemic steroids are recommended for essentially all hospitalized AECOPD patients. They work by tamping down the intense airway and systemic inflammation that's driving the exacerbation. This helps symptoms resolve faster, shortens the hospital stay, and reduces the risk of the treatment failing or the patient relapsing soon after discharge. They also seem to make the airways more responsive to the bronchodilators.
The big change here over the years has been the duration of therapy. We used to give long courses. What's the standard now?
This is a critical point. Backed by solid evidence like the RDUC trial, the standard of care now is 40 milligrams of oral prednisone daily for just 5 days.
5 days.
Emphasize that, 5 days.
Absolutely. We know definitively that these shorter courses, like 3 to 7 days, are just as effective as the older 10 to 14-day regimens. And sticking to 5 days significantly cuts down on the nasty side effects, high blood sugar, insomnia, muscle breakdown, increased infection risk. There's really no reason to go longer in most cases.
Huge practice changer. And what about tailoring steroid use? Is there anything emerging there? Yes, there's growing interest in using blood eosinophil counts to help guide therapy, particularly long-term. We know that COPD inflammation isn't all the same. Patients with higher eosinophil counts, often the cutoff used is 300 cells per microliter or more, tend to have inflammation that responds better to steroids.
So does that change the acute 5-day course?
Not really for the acute treatment. Everyone generally gets the 5 days up front. But knowing that eosinophil count can help predict who benefited most, and it becomes really important when deciding on their maintenance inhaler therapy after discharge, specifically whether to include an inhaled corticosteroid. We'll come back to that.
Okay, perfect segue into the next tricky area. Antibiotics. When do we actually need to use them? There's a lot of potential for overuse here.
Huge potential. The key is sticking to the evidence-based clinical criteria, which are based on those cardinal symptoms we mentioned earlier.
Remind us of those.
You should start antibiotics if the patient has all 3 cardinal symptoms. 1, increased dyspnea. 2, increased sputum volume. And D3, increased sputum purulence, meaning it looks thicker, darker, greener.
Or if they have just 2 of those symptoms, but one of them must be the increased sputum purulence.
Exactly. That change in sputum color or consistency towards purulence is the strongest indicator of a likely bacterial component. If they just have more clear sputum and more cough, antibiotics probably aren't needed.
Any other automatic indications for antibiotics?
Yes. Any patient who is sick enough to require mechanical ventilation, whether it's NIV or invasive ventilation, should get antibiotics. The thinking is that if they're that severely ill and decompensated, a bacterial infection is highly likely to be playing a role, even if the sputum isn't obviously purulent.
Okay, so we've decided they need antibiotics. We know the likely bugs: H-flu, strep pneumo, moraxella, KO-KSI. What are good empiric choices for the typical inpatient?
For standard, uncomplicated cases admitted to the floor, you want something that covers those common bugs well. Good first-line options include doxycycline, trimethoprim sulfamethoxazole, or amoxicillin clavulinate. These usually do the job and have decent resistance profiles.
When should we think about using broader spectrum agents, like a respiratory fluoroquinolone, or maybe something like ampicillin sulbactam?
You reserve the broader stuff for patients with specific risk factors. Think about patients who have frequent exacerbations, needing antibiotics multiple times a year, or those with very severe underlying COPD, like an FEV1 less than 30% predicted. Also, consider it if they have known risk factors for resistant bugs, especially Pseudomonas.
Like prior Pseudomonas colonization, or maybe they have bronchiectasis too, or they've been hospitalized recently and got broad antibiotics?
Exactly those situations. Otherwise, stick to the narrower agents first.
What about sputum cultures? We often send them, but are they actually helpful for guiding initial therapy?
Honestly, for the initial empiric choice, sputum cultures are generally not very helpful. The common pathogens are pretty predictable, and cultures take a couple of days to come back, by which time the patient is often already getting better.
So when should we send a culture?
Reserve them mainly for 2 situations. 1, if the patient isn't responding to your initial empiric antibiotic choice after maybe 48 to 72 hours. Or 2, if they have those risk factors we just discussed for resistant organisms like Pseudomonas or maybe MRSA, staph.
And if a culture comes back positive for, say, H-flu on day 4, but the patient is clinically much better on their 5-day course of doxycycline, do we extend the therapy?
No, this is crucial for stewardship. If the patient is clinically improving, you stick to the plan. Don't treat the culture result if the patient is better. Finish the short course.
Which brings us to duration. How long should we treat?
5 days. Just like the steroids, the evidence is very strong here. 5 days of antibiotics is just as effective as longer 7, 10, or 14-day courses for uncomplicated AECOPD. Shorter courses mean less risk of side effects like C. diff, lower cost, and critically less pressure-driving antibiotic resistance. And whenever possible, use oral antibiotics if the patient can tolerate them.
5 days steroids, 5 days antibiotics. Keep it simple, keep it evidence-based. Okay, let's talk about things we shouldn't be doing. What are some common interventions that lack evidence in the acute setting?
Right, the don'ts. First, things like mucolytics drugs like N-acetylcysteine or guaifenesin or other expectorants. While some patients might use them chronically, there's no good evidence they help in the acute exacerbation. They just add pills and cost.
What about chest physiotherapy? Seems like it should help clear secretions.
You'd think so, but interventions like chest percussion, vibration, postural drainage, they haven't shown benefit in acute exacerbations. In fact, they can sometimes worsen breathlessness and distress in a patient who's already working hard to breathe and has tachypnea, so generally avoid those in the acute phase.
We already vetoed the eosinophil. Any other meds to avoid initiating acutely?
Routine use of inhaled corticosteroids, ICS, for the acute event itself isn't recommended. Yes, they might be part of maintenance, but starting them acutely doesn't speed recovery from the exacerbation. Same goes for IV magnesium sulfate, not routinely recommended for AECOPD like it sometimes is in severe asthma.
And pulmonary rehab, that's super important, but not during the hospital stay, right?
Correct. Pulmonary rehab is incredibly beneficial, but it needs to wait until the patient is stable and recovered enough to participate, usually starting a few weeks after discharge. Trying to do it while they're acutely ill in the hospital isn't effective.
Okay, so we've cleared out the clutter. What are the essential supportive things we should be doing?
Definitely early mobilization. Get them out of bed, walking if possible. Even just sitting in a chair helps. Remember, steroids make muscles weaker and inactivity makes it worse. We need to fight that deconditioning right away. Also, DBT prophylaxis is usually indicated.
Good point. What else?
Pay attention to nutrition, especially if they look malnourished. And coordinate care involve respiratory therapy, pharmacy, case management early on for discharge planning. This team approach is key to a smooth transition and preventing readmission.
And I'd add, let's not forget about symptom control, especially severe breathlessness. We shouldn't shy away from using low-dose opioids for refractory dyspnea, particularly in patients with very advanced disease or in palliative settings. It can provide immense relief.
Absolutely. That's part of good, comprehensive, patient-centered care. Which leads us nicely into thinking about complexities, special situations, and comorbidities. AECPD often doesn't happen in isolation. What about when pneumonia is clearly present too?
Right. If the chest X-ray confirms pneumonia, you basically manage both conditions. You give the standard COPD treatments, bronchodilators, the 5-day course of steroids, controlled oxygen, but you also need empiric antibiotics that cover the typical community-acquired pneumonia pathogens, which might mean a slightly broader choice depending on severity and local bugs, in addition to the AECOPD coverage.
And thinking long-term again, this ties back to inhaled corticosteroids. We know that using ICS as part of maintenance therapy does carry a slightly increased risk of developing pneumonia down the line. So that's another factor to weigh when deciding on the discharge regimen.
Good point. What about PE? We mentioned suspecting it. How high should our suspicion be?
Really high. COPD patients have risk factors for PE, and the symptoms overlap hugely. Unexplained worsening, disproportionate tachycardia, hypoxemia out of proportion, or just failure to improve these should all trigger consideration for PE. Use your clinical gestalt, maybe a risk score like Wells or Geneva. Get a D-dimer if appropriate, and don't hesitate to order a CT pulmonary angiogram, CTPA, if suspicion remains moderate or high.
And if you find a PE?
Then it's standard PE management anticoagulation for at least 3 months, maybe longer depending on the circumstances, but you have to find it first.
What about sleep apnea overlap? The COPD-OSA overlap syndrome.
That's another commonly missed but very important comorbidity. Patients with both COPD and obstructive sleep apnea are at much higher risk for bad outcomes, including more exacerbations and hospitalizations. You should screen for OSA in your moderate to severe COPD patients, especially if they're obese, have resistant high SpO₂ levels, or complain of daytime sleepiness.
And if they have it, getting them on PAP therapy is key.
Absolutely. Adherence to PAP therapy significantly reduces hospitalizations and exacerbations in overlap patients. Addressing this before discharge is vital secondary prevention.
Finally, let's touch on palliative care. Given how serious a severe AECOPD hospitalization can be, when should we think about getting palliative care involved?
Much earlier than we often do. Especially after a severe exacerbation needing NIV or an ICU stay, palliative care should be strongly considered. It's not just about end-of-life care, it's about managing symptoms effectively, improving quality of life, helping with advanced care planning, and providing crucial psychosocial support for patients and families dealing with this chronic, progressive illness. They can be invaluable partners.
Okay, so we've managed the acute phase, considered comorbidities. Now we're thinking about getting the patient home. What makes a patient truly ready for discharge? We need a solid checklist.
We do. It's not just about surviving the exacerbation, it's about being safe to leave. First, their symptoms, shortness of breath, cough, sputum, should be back to their usual baseline or close enough that they can manage their daily activities.
What else, objectively?
Their oxygenation needs to be stable, either back on room air or stable on their usual home oxygen level for at least 12 to 24 hours. Same for hemodynamics, heart rate, blood pressure stable. All 4V therapies, like fluids or steroids, should have been stopped for 12 to 24 hours as well. They need to be able to walk, eat, and sleep reasonably well without becoming severely breathless.
So the huge piece is education, right?
Absolutely critical. Before they walk out the door, you have to be confident that the patient or their caregiver understands the discharge medications, and this is key, can demonstrate correct technique using their inhalers. So many errors happen here. They also need a clear written action plan for what to do if symptoms worsen again.
Discharge isn't the end. It's really the start of preventing the next exacerbation. Let's talk maintenance therapy optimization. What's the best first-line approach after a hospitalization to reduce readmissions?
The evidence strongly favors combination long-acting bronchodilators. That means a LAMA long-acting muscarinic antagonist plus a LABA long-acting beta agonist in a single inhaler if possible. This LAMA-LABA combination provides better bronchodilation than short-acting agents alone, and importantly, it's generally preferred over LADIAS combinations for most patients starting maintenance therapy after an exacerbation.
Why preferred over LABEGs initially?
Primarily because LAMA-LABA therapy carries a lower risk of pneumonia compared to regimens containing an inhaled corticosteroid, ICS, without sacrificing efficacy and reducing exacerbations for many patients.
So when do we escalate to triple therapy, adding that ICS to the LAMA and LABA? There's often a temptation to just give them everything after a bad exacerbation.
We have to resist that urge and be more targeted. Triple therapy, LAMA-LABEGs, should really be reserved for specific groups where the benefits clearly outweigh the pneumonia risk. The main indications are patients who continue to have frequent exacerbations, meaning 2 or more moderate ones, or 1 severe hospitalization per year despite already being on dual LAMA-LABA therapy. Or patients who have that documented elevated blood eosinophil count we talked about, usually that's a $300 cells microliter threshold. These are the patients with more eosinophilic inflammation who are most likely to get significant added benefit from the ICS component. We're trying to phenotype the patient and target the therapy.
So as the hospitalist potentially starting or adjusting these meds at discharge, you actually need to look at that recent CBC differential.
Ideally, yes. If the eosinophils are low and they haven't been having super frequent exacerbations, starting with LAMA-LABA is likely the safer and equally effective initial strategy. Getting this maintenance regimen right at discharge is one of the most impactful things we can do.
Okay, medications optimized. What about follow-up and other crucial post-discharge interventions?
2 absolutely key things. First, ensure they have prompt follow-up scheduled, ideally within 7 to 14 days, with their primary care doctor or pulmonologist. This is vital to check on their progress, reinforce education, and catch any early signs of relapse. Second, pulmonary rehabilitation.
The powerhouse intervention.
It really is. Pulmonary rehab is proven to improve exercise capacity, reduce symptoms, improve quality of life, decrease future hospitalizations, and even improve mortality. The key is starting at early post-discharge, ideally within about 4 weeks.
So let's wrap up the key takeaways from this deep dive. What are the absolute must-dos?
Okay, quick hits. Keep that SpO Euros target tight, 88 to 92%. Don't hesitate to use NIV early for hypercapnic respiratory acidosis, pH 7.35, ACO 45. Stick to short courses, 5 days for systemic steroids, prednisone 40 milligrams daily, and 5 days for antibiotics when indicated by cardinal symptoms or ventilation needs.
And for discharge maintenance?
Start with LAMA-LABA first line for most patients post-exacerbation. Reserve triple therapy, LAMA-LABEX, for those with frequent exacerbations despite dual therapy or elevated blood eosinophils. And don't forget that early referral to pulmonary rehab. Which brings us to that final provocative thought. We know pulmonary rehab saves lives and prevents readmissions. The data is incredibly strong. Yet, consistently, enrollment rates after hospital discharge are disappointingly low. There are barriers, system issues, logistics, patient factors, lack of smooth handoffs.
So the real challenge isn't just knowing the evidence.
Exactly. The critical question for all of us listening as clinicians working within these hospital systems is this. Given the overwhelming benefits, what concrete, actionable steps can we take before that patient even leaves the hospital to actively ensure they get enrolled in pulmonary rehab? How do we overcome those barriers, streamline the referral, and maximize the chance they actually start and complete this life-changing therapy? Solving that operational puzzle might be the next big leap forward in improving outcomes for our COPD patients.